a very good evening to all of you who've joined this, which is the 7th in the BSET Vascular Society joint organized webinars. This evening's session is going to cover management of vascular trauma. My name is Bijan Modurai. I'm an academic vascular surgeon at St. Thomas's Hospital in London. I have three people on as members, as co-faculty members, and it's a pleasure to introduce Mr. Paul Beavis, who's a consultant vascular and endovascular surgeon at the Bristol, Bath and Western Vascular Network, appointed there in 2015, and also a BSET council member. He will be doing a presentation for us this evening, and we look forward to that. We have two discussants, Professor Karim Brohi, who is the professor of trauma at Barts in London, and probably the preeminent trauma surgeon in the country. So we're very fortunate to be joined by him this evening. Mr. Chris Elwin, who's also a vascular and trauma surgeon at St. Mary's and Imperial. So a very warm welcome to all three of you. Looking forward to a really good session. And we will start with Paul Beavis's talk. Paul, it's all yours.
Right, let's get this to
just
share.
Before you start, Paul, what I just wanted to say to everybody who's joined us is please use the Q&A box to answer ask any questions that you have. We want to make these sessions as interactive as we can, and that Q&A box is really important. So feel free to ask anything that you wish. Paul, take it away.
Well, thank you very much, Bijan. So good evening, everyone. So I've been given the title Strategies for Vascular for Trauma, and it'd be really useful if the slides started going forwards. So here are my disclosures for this. I'm not primarily a trauma surgeon, so the way I think about this is like your normal vascular surgeon trying to deal with trauma at a time. But because I don't have a trauma badge, doesn't mean that I don't get any trauma experience, and we'll all get that on the way through. I'm primarily endovascular, and that sort of gives me, I guess, a slightly different skill set than some people. But I think it's important that, there are points in all this where you need to play to your strengths. I guess training through general surgery was a useful thing. For all the 8.5 years on the general surgery on-call rota when I was doing lap appendicectomies and thought that might not be useful, actually the time in some of the other specialties has turned out to be quite useful when it's come to some of these situations. But I do work in a major trauma centre, so that means I do get exposure to some of these things. And I've put a few cases through this as well, and these are real cases. And I may not have done the right thing, the best thing, the gold standard thing, but I'm going to tell you what I did in the moment, and then we can have a bit of a think about whether really that was the right thing or there were other things that we could have thought about. And that's why I'm hoping that the panel are going to be able to give me a bit of advice on that as well. So trauma in the UK is about 20,000 cases a year. It's in England, so it's a big thing, and it's a common cause of death, especially in younger patients. And we know from an early NC-POD report back in 2007 that a lot of people got substandard care. And with the development of trauma networks, we've seen things change. And I remember going from being the general surgery registrar, where you'd occasionally get called down to a trauma at some point, to a real change of being part of a whole trauma team and managing patients as they came through the door with trauma team leaders. And that being a very different experience. But there are still excess deaths from trauma. If you look at where the major trauma centres are in the UK, where I work over in Bristol, there is a major trauma centre and also down at the Children's Hospital. But you can be a long way from a major trauma centre, but it doesn't mean that trauma won't happen to you. If you were working the Royal Berkshire yesterday or on Saturday, you will suddenly be exposed to an uncomfortable situation. And so I guess we all have to have some experience of trauma and think about how we're going to deal with some of these difficult situations. So when you think of Bristol, you see a nice sunny part of the world, and you think, well, there won't be much trauma here. And where you work will affect the sort of trauma you get. Obviously, for people who live in the West Country, we assume that London is always like this. But I see from looking at Professor Brahy's Twitter feed today, this is really what you get when you work in London, a nice view like that. But things that we're all seeing are more bits of knife crime. So I put this slide together before Saturday, before seeing some of the stuff on the news, but there are stabbings going on all the time. But where you work does have an effect. If you work in Bristol, you're as likely to see someone run over by a tractor as you are someone get stabbed. And, you know, when you get someone run over by a tractor, they can get pretty horrific injuries. And having to do a fem pop on a 6-year-old when they've been run over by one is not the most straightforward thing you have to do. So if you don't work on the front line, as it were, being part of the receiving trauma team, although there is front door blunt and penetrating trauma that comes in, what you find is that most of the trauma that you'll end up picking up, I guess, which doesn't fit under the category nominally of major trauma, is iatrogenic trauma. So we get called from nearly all specialties at various points about difficult things that are going on. And I was sitting down and thinking which specialties, having been a consultant for only 5 years, I'd been called by at various points with problems. And that means that you can end up all over the body at different points trying to deal with things that can be quite challenging. The other thing that you get if you don't pick up people at the front door is that you often get patients who are already on the table waiting when you get called, and people are looking for you for some support at that point. So we've got the bits that you can pick up in books. So we've got some hard signs of vascular injury, the things that you'd expect, you know, your pulsatile bleeding, your absent distal pulses, expansile pulsatile hematomas, you know, through bruise and thrills and unexplained shocks. And then some of the softer signs. And these are often the ones where if you're not involved from the outset, you get the phone call from down the road saying, well, I've got this person who had a posterior knee dislocation. We're not quite sure what's going on. We've got a Doppler signal. And those are the ones that can be a little bit more challenging at times to make decisions on. So what strategies, I guess, am I trying to think about when I look at this? I think we've got to think about what we're trying to achieve at the time. Is the primary aim to save the life? Is the primary aim to save a limb? Because actually a lot of what we see tends to be limb-based trauma. And I guess we're trying to reduce disability as well. And how you achieve that can be very different in different cases. You know, there are some things that we manage conservatively. For those of us that have a strong endovascular bent, there are bits of the body that we find much easier to get to with a wire than we do perhaps with open surgery. But, you know, you need some open surgical skills as well, and you may need your friends for that. So my thoughts are that it really comes down to your vascular surgical principles and a bit more. You know, can you get to the place to control the inflow in vascular trauma? Can you stop the bleeding? Can you reconstruct it? And is it wise to reconstruct it at that point in time? And what other injuries are there? It's very easy to get sidelined down one route and miss the bigger picture. Things that I'm always trying to think about is, how do I keep an eye on the time? It's very easy for time to go past quickly. What do we do about people with their uncontrolled coagulopathy? How do we keep them warm? And really, should I phone a friend at that point? And that's sort of how I think about it, but I wonder what the panel thought about how they go about approaching these sort of situations.
Okay, so should we open that to Karim and Chris? Maybe if you start, Professor Brohy, what do you think of these principles that Paul has listed, and are there any others that come to mind that you'd like to point out?
Yeah, no, I think it's all very sensible. It's a very good sort of overview of where you start from. I think the time issue is a big deal, not just how long you're taking, but how long has passed before you were called, especially for ischemic limb injuries, which is a big source of problems still in this country. But even with bleeding patients as well, how much time has passed? How much time have I got? But otherwise, I think Paul's painted the picture very well.
The one thing I wanted to cover at some point, and this may fit here, is REBOA. Do you think that pre-hospital care, what is the relevance of that? And do you think that, if you could just give our audience a brief summary of what it is and where we are with that?
So, I don't know, Paul, were you going to cover this?
No.
No. Well, given that we're part of a REBOA trial, but we've still not had any patients who's come in with it, I think that we moot about where it might be useful, about actually, would it be useful in our postpartum hemorrhage patients, in those sort of situations, but we don't get the patients in with it already in place like you do in London.
So, I mean, REBOA, for those who don't know, is resuscitative balloon occlusion of the aorta, which is basically putting a balloon in the aorta, which of course most vascular surgeons are very happy to do and do all the time. I think the thing with REBOA that makes it different is that it's essentially done blind. It's a blind procedure done for patients in extremis or about to become in extremis. And in an effort to reduce blood flow to areas that are bleeding while preserving cardiac function afterload. I think, it's a technology that's being evaluated. It has advocates and it has detractors. It's got some very good, logically, it's got some good points to it. But again, time is a big factor. The amount of time that you can spend with a balloon up with an ischemic lower body is limiting. And in big major trauma centres, it can be difficult to understand its place in the sort of algorithm when you do have access to interventional radiology, hybrid suites, theatres. So I think it's technology that probably works for some patients, but we don't quite know who those patients are yet, hence UK REBOA.
Okay, thank you very much. So we've got one question. Chris, perhaps if you can address that succinctly, and then we'll ask Paul to move on. What principle do you use for major venous injury? Please elaborate.
Well, first of all, I'll make sure I've got a change of underwear because they're horrendous. But, a big IVC injury is far worse, in my opinion, than an aortic injury. Excuse me. It's about getting control. And getting control can be a nightmare. You think you have control. So, there are various courses that we teach on and that we teach that suggest you should use swabs on sticks to control venous bleeding, big venous bleeding, let's say the IVC. Whenever I've done that, it has failed to work. And trying to dissect out the IVC with a massive hematoma and massive hemorrhage is a struggle. So it's too late to phone a friend by that stage, but that's when you need a friend.
Okay, wonderful. Thank you very much, Chris. Paul, we'll let you carry on.
Excellent. So you look at these lovely pictures from other people's trauma talks, and I look at these and I think to myself, that is not comfortable for most of us. And actually doing things for the first time in trauma is really stressful. So you've got to think about how you can apply your normal practice to abnormal cases. So I sort of titled it under this idea of how do you prepare for the deep end, really? And my thoughts were really, you should start in the shallow end. So you really want to read your books, get out your copy of Top Knife, watch your lectures, go on courses. But the other thing that I found very helpful on the way through was tagging along with your team. So I worked with some consultants who seemed to be called by, their urology mates when they were taking out some horrendous tumours of the, kidney tumours with IVC involvement, who were always the ones on the end of the phone. when things seem to go wrong. And if you tag along with some of those people on the way and you go to other multi-specialty operations, you get to see things that you don't normally see. So I find going to, I do some stuff with urology, some stuff with obstetrics, some odd things. You see things from a different angle, and coming at things from a different place can be very useful. And the other thing is you should just learn from others' experience and talk about things that other people have seen and what you can learn from that. And the other thing afterwards is to really do all the stuff that everyone gets asked to do in their training modules, I think, which is to talk through the cases, be reflective, be critical, think about what you can do differently next time. Because it really didn't take me very long when I sat down and thought, what am I going to talk about, to think of quite a few cases that sort of sprung out like that, and then going, well, actually, did I do that the best way possible? And I think you've got to have that thought process as well. So my thoughts are that you can start with planning in pseudotrauma, he says. What do I mean by that? Well, this is a patient who had their spine fixed when they were 18 years old. And I got referred them from one of our local spinal surgeons when they were 21 with this screw that's already sitting in their aorta at that point. And this is great for your practicing side of things and thinking about how you're going to approach difficult situations, because you've actually got time to plan, you've got time to sit down, and you've got time to look with your colleagues about things. And actually for this young lady, we put her on the table in the hybrid suite, and we put some wires up, and you can see that the wires sit around that little screw that's sitting in the aorta there. And then we put her on her side, took the screws out. There was a tiny pseudoaneurysm. We followed it up and we did nothing else with it. But actually the thinking time that went with that, so what am I going to do primarily? What am I going to do if that goes wrong? And how am I going to get out of that? Was very useful. So I think it's important that you apply the learning from those cases so that when the pressure's on, you've got something in the back of your mind to go back to and think about. And what you find is if you do a few silly cases, they'll start ringing you about other things that start coming through. So this lady who came in having had a DHS done in January of this year, who turned back up in June with this poking out into her pelvis. And actually, you've got time to think, you planned it, and we just did an extraperitoneal approach. It was stuck right on the back of the external iliac vein, and it came out without any problems at all. And I wondered which other specialties, Chris and Kareem, you've learnt from, and which ones have been the most sort of valuable that you've applied into your trauma practice.
I probably do a lot of my operating with plastic surgeons, actually. And although they're very slow, they're quite good. And
so no plastic surgeons have logged on, huh?
They know their anatomy. They're about, one of the very few specialties that literally will go in any body cavity or region. In my trauma practice, maybe not operating with, but I mean, we do a huge amount of MDT work with other general surgeons, with neurosurgeons, and even the non-surgeons are awesome. Again, that's not going to help you at 3 o'clock in the morning, but we can learn from everyone, I think, and if we're open about it and not assume that we are unteachable, then we will only learn.
Okay, thank you, Chris. Paul, why don't you carry on, and that'll leave us a bit of time for discussion later. Okay,
here we go. So I've brought a few sort of cases along now. So these are ones that you sort of get served up. Now this has the pleasure, you get a single slice of a CT scan, so you never really get the full picture. This young gentleman, he's 39 years old. The neck of the weapon of choice in Bristol does seem to be the machete, but I think that may just be a general term for any large knife applied to anyone at the time. So this young gentleman, who already had a number of depressed skull fractures from previously being hit round the head with a hammer, had put his left arm up in front of his face to just slightly deflect the blade that was sliced at him. And this has come in just under his jawline on the right-hand side there. And I came in the morning to find this guy was on ITU. And my colleague from overnight said, we've packed the wound overnight. We've not had any more bleeding overnight. And actually, we've got a decent CT scan now. And I think this is one of the cases when it's actually quite nice. You've got some pictures and you can sort of plan a bit. I always worry about those points where, you know, you're right up under the jawline, you're right down by the clavicle, all the bits that are really tricky to sort of reach and start falling out of your comfortable area. But actually, having time to plan, once he'd got in, he found he'd just gone through his internal jugular vein, which we repaired, and explored around the carotid, and everything else was fairly straightforward, apart from taking out a bit of a salivary gland, which I'd never done before, while the MaxFATS consultant looked at me and said, that's all you've got to do. But those areas are the ones that worry me personally, because, you know, I do carotid subclavian bypasses as part of my complex endovascular practice. That's done. But actually diving down further into the chest fills me with dread. And personally, that's the sort of area where I'm sort of interested what other people think about. For me, it's much easier for me to get to that with a wire than it is for me to get out a scalpel and get to it in any kind of competent, hurried kind of way. Is there any good way of getting to those areas?
Kareem, why don't you give us an opinion on that?
So I think with all of these questions, there's no one definite approach. It depends very much on where the injury is, obviously. It depends how much time you've got in terms of what the physiology of the patient is like. Depends what your skill set is, and it depends what you've got around you in terms of the hospital, the availability of a hybrid suite or IR, or you've just got a plain operating theatre. Do you have 5 minutes, or do you have plenty of time to plan? So, I think for each injury there are a set of approaches which you can tag along to other teams, but you'll never actually get to every possible injury. And many of these things you can think through in your head, actually. What do you do if you have an injury to the third part of the subclavian? What do you do if you've got an injury to the second part of the subclavian? What do you do if you've got an injury to the first part of the subclavian? What do you do if you'd like to put a balloon in the first part, ideally to get proximal control? So if you've got time, can you do that in IR? Do you have to do it in the operating room? If you do it in the operating room, what do you need to get there? If you haven't got time to put a balloon up, what's your approach to proximal control? Do you get it in the, are you going to do a stenotomy? Can you do a stenotomy? Do you have to phone a friend? Otherwise, you're going to do a thoracotomy, and where are you going to do it? How are you going to do it? So I think, as Paul says, prior planning is everything. And a lot of that is about decision making. What can you do? What can your hospital do? What can everyone else do? Some of them are a nightmare. The big arterial injury behind the jaw can be a nightmare. And some things you can't get hold of. Ones that go up to the skull base, you can't get hold of no matter what you do. But at least you can have a good go.
No, I think I think that's what I'm trying to get to. Really, I think is that there are some things that are just so difficult, and they're difficult for everybody. I think. I don't think that not sure if they ever become comfortable for anyone.
No, I think the thing is that that you've done everything, and that you had thought through it before and you gave it a good go. It's if the first time you've ever thought about it is if when you're presented to it and you haven't got a lot of time and everybody's looking at you, and that's not a good place to be in for any procedure. So thinking it through, talking it through with mates, whatever, is always helpful.
And then the other thing, obviously, is not be set on continuing what you first planned, because, well, as we know, in vascular surgery, it can come and bite you. So be prepared if you are not succeeding to think of plan B.
Mm-hmm.
C, D.
And so, all right. So I've got another case now. So this is another joyous one. So man in his 30s, who was walking back in Bristol. He was been out for a few drinks when a drunk driver came down the road. He pushed his girlfriend out the way and was pinned by the car against a wall. The car driver then, the bid to get away, spun the wheels in his left groin at that point. And I got a call saying, we've got a man who's on the table at the moment. Can you come and help? So I walked in to find, and there are no pictures for this because, you're called in that time, a sort of pulsatile truncated end of an SFA sitting there entirely in spasm with no blood coming out of it at all. A large volume of tissue loss in the groin and thigh with significant genital and perineal injuries as well. So I turned up. There was also the orthopedic surgeon, the plastics, urology and general surgery, all sort of sitting there, we're all sort of staring at this man. So my thoughts at the time were, well, is this leg really salvageable? I guess was the first thing when I looked at it. How to revascularize it, but really, first of all, how to buy some time and what to do first. Because you had a man who was going to need probably a stoma. It looked like he was going to need, well, probably suprapubic because it looked like all his genitals had gone. So I, for this guy, put a shunt in and I guess learnt on the way, as I was doing it. So I put it in from the end of the SFA that was poking out nicely. There was sort of no artery really to see. And then you could sort of almost see into the top of the knee joint. So I put it into the below knee pop, which was too far for anything that we've got sort of sitting on the shelf, for a normal carotid shunt. So I thought I'd be sensible, get out a big bit of tubing. So I put the blood giving set in the top end, got to the below knee popliteal, realised that was far too big to go into the below knee or popliteal. So I put in the IV giving set there and they slotted together in the middle. And actually all that did was create sort of a bridge to decision, I think, because putting that in revealed all the venous injury in his leg as well, revealed how bad his leg was with that, as you were saying before, not knowing how long that leg had been ischemic before you actually got to theatre with the guy. And it really made him very unwell at that point. And so actually we ended up taking his leg off above the knee sort of at that point in theatre with a sort of a group decision, I think, to do that.
So
how do you find with shunts?
So there's a few questions that have come in related to that. This reminds me of a story when I was with a junior to Kevin Bernand, who was a very bombastic professor of surgery at St Thomas's, who got called in to reconstruct an artery, and the trauma specialist then came in and amputated the leg afterwards. So you can imagine, in the same sitting, you can imagine the sort of blood and guts that were around on the walls after that. So one of the questions that has just come in by the audience is the role of the mangled extremity score before we consider reconstruction. So did you consider that in this case, Paul, you and the team?
Well, my thought, not really, I guess, is the answer. The first thing I was trying to do is put a bit of blood down to the bottom of the leg so that we could work out, really, was there an option? My experience is that whenever I do anything with a plastic surgeon around trauma, they think that everything is salvageable, and you can end up with a pure bit of artery and a little bit of bone, and not much in the middle, and someone promising they can put a flap on the middle of that at some point, and me thinking, I'm not quite sure that's going to work as well as you think it is.
Okay, so let's open this out to perhaps Kareem first. Kareem, can you comment on two things? One is the role of the mangled extremity score and how you use it. And the other is another question that's coming from those tuning in, which is, if you did, for example, have to reconstruct that artery, would you use prosthetic or vein? Because they're suggesting that in the practice in your region of London is to use prosthetic rather than vein. Is that correct? And what are your thoughts?
So, where to start? So I think, so I don't think anyone uses the mangled extremity severity score or any score to decide on salvageability. You know, it's a sort of retrospective tool that got somebody a paper, but is not really applicable to anything. And I think the basic tenet is you try and save the limb in the initial phases unless it's killing the patient. And, you know, there's never, usually in trauma care, that, like many things, there are multiple points where you can make a decision to take a leg off, that something isn't working, that you need to withdraw care on somebody. So you don't have to make it at that point necessarily, unless it's killing the patient or unless it's just obvious that this leg is going to be functionless. And often, you know, the two heads are better than one, or three wise people type approach to that is helpful. You know, getting a colleague in, consulting with the anaesthetist to, you know, actually make a decision about what's in the patient's best interest. I think, you know, restoring blood flow as quickly as possible is the right way to go, and shunts can be helpful with that, especially if you've got some skeletal stabilization to do. And they don't last that long, shunts, in my experience. I might not be very good at putting them in, but you know, I find that they'll maybe last the operation, or they'll last an hour or so after the operation, but you'll need to redo them pretty quickly. So I tend to use them intraoperatively, temporarily, rather than you know, come back the next day type thing. But I think they can definitely be useful in restoring flow quickly and then reassessing, as Paul used here. I always use prosthetic for every emergency vascular repair. And I know that's anathema to many people, but it's faster. You know what you're dealing with. You don't destroy what little vein you may have to do something that may not work. And especially in infected areas, prosthetic fails reliably. You know where a prosthetic graft is going to fail. It's going to fail at the anastomoses, and it usually fails in a controllable way, whereas vein will disintegrate and just fail in a catastrophic way. So I would always say vein if I need to for a subsequent reconstructive procedure, which is very rare, and I always put prosthetic in. That's not necessarily the practice of my colleagues, so it's not a definitive answer.
Thank you very much. Chris, a quick question, perhaps if you and Paul can answer that, and we do have to be conscious of time. Two people have asked about reconstructing arteries in those who are growing. Are there any considerations, for example, reconstructing the SFA in a child? Do you need to worry about what happens when they grow or not?
No. Just
brilliant. That's just what I was looking for.
Do what you need to do at the time, and then deal with anything as it comes.
Thank you. That's very succinct.
Paul,
why don't you carry on so we get through everything?
Okay, right. So this is a few weekends ago. So Sunday PM, if you're on call weekend, you think you've made it through the weekend all right, things are going fine. When you get the phone call from the on-call anaesthetist saying, I presume you know about this person we're taking to theatre now. No, should I? Well, he's had a machete through his leg. His wound's packed. He's got this compression bandage on and 2 tourniquets, and he's sort of all right when he's like that. Oh, right, okay. So you go into the hospital to find them already wheeling him out of resus. The only thing that I changed on the way up there is, could you take him to the hybrid theatre rather than to the main operating theatre at that point? So I got into theatre, and this is how I went about dealing with this thing. So you got a man with a large hole in sort of mid-thigh on the left-hand side. I started by, well, we started by opening up the groin to get some proximal control, taking the tourniquets off, realising you needed to clamp the vessels because actually the SFA is in two pieces and it's gone straight through the middle of the knife with two ends. The SFE is slightly more ragged. There's lots of bleeding from the muscles. And then you pull things out and wonder what's going on, and you realise it's the operating table underneath the bottom of the leg that you can see, because actually they've gone through everything. So I mobilised the SFA and joined it end to end, because actually it was remarkably clean and the ends came together without any real problems. And I guess I was told it was like 2.5 hours from when it happened to when he turned up in ED, and we're probably another hour down the line by now. If you took the clamp off the profunda, you got quite a lot of bleeding out the muscles at that point. We did some fasciotomies and got significantly more, I guess, calf bulging than you'd expect from someone who'd only had a couple of hours of ischemia, or 3 or 4 hours of ischemia. And then, being an endovascular surgeon by trade, you take your angio to think, this is going to look good, I hope, at the end, and find that there's a whole lot of clot sitting just there in your at your TPT, with not much blood going into the foot. And at this point, actually, while I was doing the angio, I realised that the thigh was tense as well, so we opened up the other bit of the thigh that wasn't open, got a lot of bulging there with healthy muscle. And the foot sort of has that look of okay-ish. And as everyone knows in vascular surgery, okay-ish generally is when you're trying to convince yourself that it looks all right, but it probably doesn't look all right at all. And this is where I get to sort of, you know, your timeliness things, because getting your popliteal out with your trifurcation in order to do a popliteal embolectomy does take a little bit of time to do it. But I didn't think we could leave the foot like it was. So we did a popliteal embolectomy, got some flow back to the foot. And you know that it's worked well when the response from your anaesthetist is, the anaesthetic just got interesting. At which point your 30-year-old man has got cardiac arrhythmias and a potassium of 7.3. And he goes off to the unit, gets a CK of over 100,000, comes back at a couple of days and his gastrock's really dead, and that comes out. He's on the filter, of course, at this point, and then has his leg off sort of 4 days down the line, but he's alive. And I just, you know, those are the things that we're seeing more than we've seen before. You know, one of my colleagues had someone who was shotgunned in the same sort of area the other day as well. And I guess we're going to start seeing more of these with increases in amounts of, you know, knife crime, and the drug violence seems to be sort of starting again now that people are coming out of lockdown. And I spent a bit of time afterwards thinking, you know, well, would shunting have made any difference? I don't know. Should you always stick an embolectomy catheter down to the calf when you're about to stick the two ends back together, even though there seemed to be some good back bleeding? Should have done fasciotomies earlier. Would that have made any difference? And in patients who've all had, you know, TXA on the scene and have had tourniquets on, does that always cause runoff problems? Because we seem to see quite a lot of runoff problems, and I don't know if the two are related or if it's just part of the deal with having leg trauma. What do you think about that, Chris?
I mean, I think the first thing I would say is trauma is a team game. So you can't do any of this in our vascular bubble. We have to know what is going on. We need to know the time. We need to know what the physiology is. You know, some of us like to say that trauma surgeons are physiological surgeons as opposed to anatomical surgeons. So what we do is so determined by what the patient's physiology is. And if you don't know what the physiology is, then you potentially are going to do the wrong procedure. Would you have shunted? Possibly, maybe, but it depends on the physiology. Embolectomy, I'd like to think that I would, but I don't know if I definitely would. And certainly one of my colleagues, David Knott at Imperial, he will always start with a fasciotomy. I don't know the evidence behind it, but he suggests that that improves flow, microvascular flow. I don't know if that is true. The other thing to say about tourniquets, that if somebody has put 2 tourniquets on a limb, that generally means that it really needed to be there. Some of our colleagues and in the hospital colleagues are always keen to release fasciotomy tourniquets in the emergency department, and it's not always wise to do so, especially when there's 2 on there. TXA, I might leave that to Professor Brohy.
So one of the questions that's been asked about TXA is how often it's used and what benefit it has. So perhaps when Karim answers that, he'll include that as well. Chris, one of the questions that's come through is if you had, or anybody on the panel, if you had an arterial and venous injury, what are the rules about which you repair first? Do you repair the vein or the artery? And what are the indications to tying off the femoral vein?
So you can tie off anything. And again, that's part of the whole damage control scenario, like the primary amputation. If it's killing people, tie it off, amputate, whatever it might be. I would try to repair both if I can. I would concentrate on the artery more than the vein. Lovely,
thank you. Karim, do you want to talk to us about tranexamic acid a little bit?
Yeah, so I think just keep it simple, and yes, you should always give tranexamic acid to these patients, especially if they got multiple injuries. I think having clot later on is a function of stasis in the limb beyond, even a low flow state, never mind a tourniquet, combined with better general coagulation management during bleeding that we're seeing now. It's kind of inevitable. Not that I put an embolectomy catheter down all my cases by any means, and I definitely don't do angios post surgeries. I would go against the doing a fasciotomy before you start argument. It makes no sense at all to me, because you don't get compartment syndrome until you've got perfusion. And restoring flow to the limb is the utmost priority. I've never understood the argument for doing a fasciotomy first, and I think it delays things, can increase bleeding once you get flow restored and things. So I would always concentrate on the artery.
What are your rules for heparin? You never give it intraoperatively while you're repairing the vessels?
I don't have a rule for heparin. I tend to play it by ear, depending on how coagulopathic the patient has been during the procedure, what the blood looks like, how long I think I would be. There's not a lot of science behind it, I'm afraid. I think it's just experiential. If the patient's oozy, you wouldn't give it. If you've just done a repair that you're concerned about, I'll often heparinize people post-op if there's no contraindication.
Okay, thank you. Paul, do you want to carry on?
So I'll give you so this is the last case, but this is my ultimate sort of horror case, just so that everyone can think I'm glad that didn't happen to me. So I was meant to be doing a placenta precretia operation with a nice friendly gynecologist, and the lady decided the day before that she didn't want her internal iliac balloons in. But we'd already booked her onto my hybrid operating list, so that was fine. So I went off with my interventional radiology colleague. We're having a nice cup of coffee and a bacon sandwich, thinking we've got out of a morning's work and feeling quite pleased with ourselves at that point. When there's a call from Resus, from one of the sisters, saying, can you come down and have a look? Because no one's really making decisions down here. And I'd just like another pair of eyes, if that's all right. So I trotted on down. Found a 50-year-old cyclist. He'd arrested on the scene and in resus. And we all sort of made a decision at that point that we were going to stop. And then we checked for his pulse and it had all returned. And this is when you get what I find to be one of the most difficult statements that comes and puts you in a very awkward situation, which is, here is a patient who is too unstable to scan. We think we can move them once, but we can't move them again. What do you want to do? And so they were taken to an operating theatre. And you've got very little information before, but I suggested we should probably do some plain films before we went, just to see what we might be dealing with, not really knowing where the unspecified bleeding was coming from. And you get a pelvic x-ray that looks like that, and you think, well, that looks all right. And then you get a slightly rotated AP chest x-ray that looks like that. And you've got two chest drains in, you've got the defib paddles on, which is always a bit of a giveaway that things are bad. And I can't help thinking to myself when I look at that, I'm probably going to be in quite a lot of trouble dealing with this, potentially. So I'll tell you what I did, and then you can tell me if I did the right thing or not. Well, who knows? So we opened his chest as sort of the first place, and you could find a large anterior mediastinal hematoma and a large contained hematoma superiorly. The lung sort of looked all right. There was no pericardial tamponade. There was nothing obvious within the chest at that point. Did a laparotomy, and there's no large obvious injuries at the point. And then, because you've had a bit of time, they say it's a bit more stable. We think we can probably get him to the scanner next door now. Yeah, well, that would have been helpful the other way around, I think. But so we took him round to the scanner, and it picks up, I guess, 3 major issues at that point. That's his innominate artery. So talking about junctional things and places that are difficult to get to. There's his transected descending aorta. And there's a bit of bleed in the mesentery at the terminal ileum, which I had pointed out to me as well. So the gynecologist is still merrily getting on in the hybrid theatre with getting a baby out of a lady, and so you can't get into there. So we went to interventional radiology. And unfortunately, what isn't stored from those pictures at the time is the zip wire going straight out the side of the aorta at the point of transection, sort of free floating into the chest at that point before it goes around the arch. So we put a thoracic stent graft in, and talking about ways where you're better equipped to get to places using your normal skill set, we put a stent across the innominate as well. But I think you can probably predict where this sort of thing goes. He's already had 80 units of blood and blood products at that point. His pH is unrecordable. So I got one of the trauma intensive care military consultants in just to say, and we all had a bit of a chat as a team and said, well, are we going to carry on at this point, or actually have we done what we think we should do, and should we actually stop? And we decided to stop at that point. And I don't know if I could have done anything differently. I think we're probably onto a loser from the start, but you know, those are difficult cases, and those are the cases that you think about afterwards.
So Paul, would there have been any opportunity to get this man to have an angiogram prior to opening his chest?
Not in the theatre we were in, no. So if we'd gone straight to interventional radiology instead of a theatre, maybe. In retrospect, yeah, we could have gone to the interventional radiology suite, but then if we'd actually needed to do any operating, we couldn't have done it in there. Well, unless you did it with a headlight.
Agreed. Okay. Kareem, any comments on this case?
So I think it's very difficult to take a patient like this to the scanner. because, you know, you can be, you know, nobody's happy where this patient's going to go because this patient's not going to survive one way or the other. And but it's very difficult, I think, to go to a scanner with a patient who's just come out of rest and is hypotensive and things. But I think if you go to the operating room, you're either going to do something diagnostic or you're going to do something therapeutic. And in this case, Paul took him to do something diagnostic. I think the thing to say is that he's not arrested because of that aortic injury, because there's no blood coming out of his chest drains. So he's not lost a lot of blood from there, unless he had a tamponade. I think excluding a tamponade is the right thing to do, whether you do it operatively or with an ultrasound. Could have been losing blood from that bowel injury, although it didn't look like there was loads of blood in the...
Not much to see in the abdomen at all.
So, I mean, it looks like he's had a big blunt injury, which has just taken him out, basically.
Could the laparotomy have been avoided? So what about doing a fast scan, for example? A quicker way of imaging the abdomen rather than a laparotomy?
You can do, but I think if you're in theatre, it's quick to do a laparotomy, a small laparotomy, and see what's going on. I think it's the right, you know, I think people are afraid of doing laparotomies, but I think if you're there, it's the quickest and fastest way of excluding something important going on in the abdomen, and just get on with it, I think, rather than trying to get an ultrasound. If you're still in resus and you've got an ultrasound, then absolutely I would get a fast scan done. But I think, you know, if you've arrested post-blunt trauma, okay, you've come back, but you're still hypertensive, you've got big problems, and the chances of surviving are pretty minimal. I think you did well to get them as far as you did, and it's I think it's absolutely the right way to repair the injuries that you found. But I think you're probably on a hiding to nothing from the beginning.
Okay, so I think we've got time to answer some of the more generic questions that pertain probably to a few of the things that we've talked about. So perhaps we'll use the extra time that we have for that. We've got about 15 minutes. Chris, why don't you take this one? One of the questions that's come is to talk a little bit about the role of the vascular surgeon in the trauma team. I think you know, some people think that we're an afterthought as far as trauma is concerned. And, you know, so talk to us about service provision, what the role of the vascular surgeon should be, and maybe trauma training, past, present, and future.
Blimey, okay. Well, I mean, I suspect Karim and I are a little bit biased about it, but, you know, we both went through not dissimilar training as general and vascular surgeons, or general surgery with a vascular interest, and did fellowships in trauma. And, you know, the Royal London Service still and was and still is vascular surgical led. It does worry me a little bit that we as a specialty have split from general surgery in terms of trauma provision. And in terms for future trauma surgeons or people who are interested in trauma, which specialty should they go into? Should it be general or should it be vascular? Because you need skills from both. And I'm as yet to be convinced that without extra years or fellowships, that the either training scheme could produce trauma surgeons. I think with TIG training, so training interface group training in trauma is a big step forward. It's difficult, but I think in terms of vascular surgery, when, you know, the big bleeding starts, everybody else panics, and it's us who are called. But in a lot of trauma centres, mine included, vascular surgeons are not part of the trauma team. Largely through service decisions. Okay, Chris, thank you very much. So I'm conscious that Paul has just a few slides to finish up, but just before you do that, Paul, there's a number of questions coming up, Karim, related to use of synthetic material for reconstruction in trauma. So the points that are being made is
does that increase the risk of infection? And do you use that for children in the same way as you do for adults?
So there's a number of questions on children. Children are very, very difficult. Vascular trauma, vascular anything in children is horribly difficult, which is why there are almost no pediatric vascular surgeons. And pediatric trauma care can be exceedingly difficult. Just in terms of principle, whenever possible, don't do anything to a child's limb. If you can possibly avoid it, don't do anything. I'd be freer to ligate things emergently in a child. If you are repairing, try and do primary repairs without graft. If you are repairing, most grafts that you have are going to be too big for a child, and you're going to have to find some veins somewhere if you've got time. But kids are pediatric vascular surgery is different from adult vascular surgery, definitely. So the prosthetic graft issue is something that exercises vascular surgeons no end, because of just, I have no idea where the historic thinking came from. But there is, if you put a vein into an infected area that you've taken from somewhere, it's basically a dead collagen tube, and it's no more or less likely to get infected than the prosthetic graft. Certainly not in a primary procedure, emergent procedure like this. My key reason for, two reasons I said for using prosthetic is it's faster and it does less damage in these emergent situations. And the second one is when they do fail, they don't fail by killing somebody, because when they blow out on the ward, you'll get a pseudoaneurysm at the site, you might get a sentinel bleed at the anastomotic site, and you can deal with it, and then you've saved vein for those cases where you rarely need to repair them. But a vein that gets infected just disintegrates, blows out on the ward. Patients often dead or near dead on the ward or at home, and it's hopeless. So I always use prosthetic. It may not be the answer you want to give in your FRCS vascular.
Thank you, Curry. Paul, let's see your final few slides. Thank you.
Last couple of slides. I tried to summarize what I thought about things. So I thought my personal do's on this is that intervention needs to be timely. If you can scan, because you've got time, do. Make sure you get someone to actually keep a measure of the time, so that you know what time is going past. And sometimes you'll say to the anaesthetist, can you just tell me at 15 minutes? And then we'll just do mini updates, and we'll say where we are and what's going on, and are you winning, am I winning, and how are we getting on together. I think that's important. You need to do what needs to be done right now. There are other stuff that you may not need to do that you can do on another occasion. You should get help and talk things through if you're not sure about what to do. And things to try not to forget. Well, actually, as we've said before, actually the coagulopathy side and what we give to patients in trauma has changed quite a lot in the time I've been working as a trainee and as a consultant. I think we're better on the coagulopathy. We'll tend to use Rotems in theatre or TEGs depending on which hospital you're in at the time. Try not to let the patient get cold. Don't forget about other injuries. Do think about controlling the contamination. Speaking to the relatives is really important as well, so they know what's going on. And do take some time to reflect and think about your own well-being as well. So I'm now going to put in the bit that your average consultant vascular surgeon doesn't put in, which is that trauma goes both ways. I've got a colleague who's been very deeply affected by working in trauma, which happened to one of my best friends. You can be thrust into very uncomfortable situations that, and this may have longer term impacts on you. And it's all right to do that, but you just have to recognize it in yourself. And there are lots of people out there that will support you. After the guy, I put the images up before, the cyclist, because that was quite similar to how one of my best mates died. The biggest problem I had afterwards, there was the number of coffees that the anaesthetic department then fed me, because he was a consultant anaesthetist, because they wanted to make sure I was all right. And you want that support network around you as well. And I think that's really important. And that is all I have to say.
Paul, that was a really, really fantastic talk. It was a really nice way to frame the discussion. So thank you very, very much. We've got about 10 minutes left. So if the panel are willing, we will work through just 2 or 3 more of these questions. So trauma training. Somebody's asking, is it true that the trauma TIG is going to be stopped? It's something they've heard on the grapevine, and if so, why?
I am not aware of that. I thought it was carrying on, but...
Okay.
So I've heard similar on the grapevine, but I haven't heard anything definitively, and who knows why.
Okay. There's another question about the role of endovascular intervention for IVC injuries. What is your experience of that? Do you think there's a role for it?
I have no experience, and not convinced there is a role.
Yeah, I don't. Paul might know more than me, but I've been involved in a couple of cases early on where we tried to stent graft the IVC, and the problem is the IVC gets bigger than the stent graft quite quickly, and also it's quite difficult not to obstruct the veins that you've got renal veins and hepatic veins around there, usually where it's torn. So I've never had much success with that, but I think Chris was a bit negative about the IVC. Most IVC injuries you can get hold of if you've got an approach.
You're a special man, Professor.
Yeah. I've watched the split disappear up and down past my fingers, and yes, been in a world of trouble myself.
Yeah.
Okay, well, let's switch from the IVC because it scares us all to the knee. We're a bit more comfortable there. In case of a posterior knee dislocation with popliteal disruption, would you opt for revascularization first, or let it be fixed from the skeletal point of view first? And that's a couple of times people have asked that. Fix first or revascularize first?
Reperfuse first. Whether that's fixing or shunting, it's down to the case, but always reperfuse first in my book.
Yeah, I'd agree with that. I think very occasionally you get somebody who comes in very quickly or who has some partial flow to the foot, and you can fix temporarily fix them first with an X-fix, but usually the orthopods don't disturb your repair as much as everyone's afraid of, and especially if you watch them while they're messing about. So I would fix the RP first too.
Is there a role for thromboelastography to assess coagulopathy in trauma patients? Is another one of the questions.
So in trauma patients, probably, although the book is not definitive on that, in terms of how you manage coagulopathy in general. I don't think there's a role for coagulopathy in deciding whether you should heparinize a limb post-repair or not. I think that's more about prophylaxis rather than treating a coagulopathy.
Okay. Paul, is there any other words of wisdom that you want to finish with? I thought that was a really nice talk because it used real life cases. Bristol seems to be a very dangerous place.
Well, I don't know about that. I mean, it's not London, is it? It's just all the people that get injured come to me. It just must be my role as the fecal lodestone of the department.
So maybe just to finish with, Kareem, can you give us any insights on the trauma networks and what changes, if any, do you foresee in the next few years as far as reconfiguration is concerned? Do you think the trauma networks are working? What sort of difference they've made? And how things may change?
Yeah, I think on the whole, trauma networks made a big difference in terms of getting people to the right place in a timely fashion. So, the patient that Paul presented at the end probably wouldn't have made it to hospital in a few years ago. So I think, and I think there's better care in hospital, there's better education in general. I think reconfiguration of networks is going to come because other services are going to be reconfigured around trauma, and trauma is going to have to deal with that in order to maintain, timely, efficient services. So there's still work to be done, but I think it's way ahead of most reconfiguration and restructuring we're about to see.
Okay, I think with that, we will bring things to a close. We're already getting a few messages to say what a great session it's been, and I'd concur with that. My thanks to all three of you. It's been a really, really good session, I think. And I hope that everyone has an enjoyable rest of the evening. Thanks very much.
Thank you. Thanks, Paul. Well done.
Thanks, everyone.
Thank you.